right, so this is really regarding a management case of a patient's. It's challenging transfemoral case. And this is a patient who I know her for about the last 3-4 years, 60 years old woman who referred by a cardiologist from Phoenix for debilitating lightheadedness that she's not able to stand and has severe supra-aortic trunk disease. And the multiple sclerosis and coronary artery disease had multiple stents, had history of papillary thyroid cancer, thyroidectomy, radiation, and laryngeal stenosis that required multiple laryngeal dilatation. Vocal cord paralysis had due to vagus nerve injury during one of the procedures, had a bilateral carotid stenosis, require bilateral carotid CEA back 20 years ago. Now had a left carotid stent that was complicated by intra-procedure stroke, had a multiple left subclavian stents. So this is a patient come to me. When I saw her, unlike the case I saw earlier, has a big old guy, big, really obese guy. This is a very skinny woman, had a severe shortness of breath, severe wheezing. And so first thing I did, well, you need to see a pulmonologist. So send her back to her primary care and cardiology. She was found to have hypertensive cardiomyopathy. I was told that was a reason for her severe kind of pulmonary issue, which I don't quite understand the pathology, but she was treated and she got better. She had bilateral upper extremity pressure within fairly normal, 100 to 120 millimeter mercury, but her central pressure about 100 millimeter mercury higher. So she's actually lives in about systolic pressure about 200 to 220. That was her, she's being chronically severe hypertensive. So first thing we did was try to figure out what's her real pressure. Now, knowing that she may have some sort of Takayasu pathology, so I decided to look at her pressure gradient and look at basically with catheter pullback. She didn't really have a supra-aortic, ascending aorta all the way to the iliac artery. Luckily, she didn't have lots of gradient differences between ascending aorta and iliac artery. So that tells me that her leg pressure probably is better to measure for her pressure control than her arm pressure. So that information went back to cardiology. She was a little better managed. Now her pressure is in a better range. She still have more frequent lightheadedness. So now so this is her CT scan in 2022. I'll just point out a few things. She has a left carotid stent all the way from the arch, extend to the ICA. And right carotid severe stenosis at common carotid origin. And left internal carotid, there's either calcification or stenting. I couldn't really tell. I mean, I still to this day, I don't know if she had a right carotid stent as well, but she has really calcified artery there. Severe calcification in the aortic arch. And here's the subclavian, left subclavian artery. Has stenting at the origin, is patent, little stenotic, multiple stents in a subclavian, and then look like there's two stents separate, and then one stent kind of in the middle. And if you see the most right-hand side, there's a almost a radiolucent area. I think it's probably either a small thrombus there. Again, severe calcified aorta. So this is really a disaster patient. I was really kind of trying to figure out what to do without giving her another big stroke and try to treat her so that she can be better, be able to actually walk comfortably. So this is the first angiogram and did the aortic arch angiogram. So left common carotid stent and left subclavian stent, they're very close together, and they're all in aortic origin. Now, do you treat left subclavian stenosis? The first thing I thought I would do something easier to do. Instead of tackle the carotid, let's just try to do the subclavian. Do you treat subclavian stenosis? I didn't, because I didn't want to push a plaque towards the common carotid, left common carotid, which already severe stenotic. She has a patent vertebral artery, but stenotic. And that vertebral artery sits in between the two stents. She has severe stenosis at the distal stent. There's a two stent distal to the vertebral artery, and severe stenosis. But if you look at where it is, it's right in the first rib. So I did angioplasty as very minimal, try to get her a little better pressure. And really, this is really for me to see if she can get a better pressure of the arm for better pressure control. And did angioplasty, and you see the stenosis on the balloon. And distal is better. I did not really want to tackle the first vertebral, the proximal vertebral artery, because I'm afraid of pushing the plaque towards the common carotid, the left common carotid. So that's a first. Then 3 months later, I brought her back for the look at the, hopefully improve her right vertebral flow. And she has severe stenosis in the right common carotid artery and the right subclavian artery. So I tried to look at subclavian artery, see if there are any more lesions in the subclavian in the middle picture. So she has stenosis distal to the vertebral artery, severe stenotic vertebral origin. Now, at this point, I went through arm approach and tried to retrocannulate the subclavian artery, and then decided to put a kissing stent there. So that's a kissing stent. It's not perfect, but it was better. I didn't really want to go to the distal, middle distal subclavian for afraid of pushing the plaque towards the vertebral artery, occlude that vertebral artery. And didn't really go further into the carotid either, because I wasn't sure exactly, it's going to be full metal jacket on bilateral carotid. As you can see, there's on the, there's just, well, you can't really see it, really severe stenotic on the left common carotid artery. So patient had, we managed the pressure, thought a little better, thought it would try to manage better. Then patient had transit left arm weakness in the PACU, resolved on post-operative 1. Then we did an MRI to looking for acute lesions. This is a DWI MRI. You can see a hypertensity on the DWI imaging. That's acute embolic event there. The MRA shows the two stents in patent. Because of its MRA, so that there's an artifact of the metal. So what you see is actually patent area, which we're pretty happy about that. The area you see stenosis is really the artifact. However, the left common carotid artery still have a stenosis, and it's still both distally and proximally. And then the right vertebral artery has atrophic distally, so that's contribute to a distal really low flow there. No, and this is a perfusion scan. There's no territorial infarct. The increased time to peak and the posterior fossa, deep white matter, and the watershed area. So she still has pretty, have a low perfusion overall. On the T2 flares, looking for chronic lesions. So have a chronic embolic bilaterally. And that on left side, I'm not sure, it could be from my procedure 3 months ago. But that you can see multiple wide lesions. That's from the chronic embolic events. So now 3 years later, she has improved her lightheadedness, and she's using a cane, walking around instead of walker. She comes to see me every 6 months from Phoenix. And we use bilateral lower extremity for hypertensive management, allow permissive hypertension instead of 120s to 160s, so that she raised her intracranial pressure. She has improved hypertensive cardiomyopathy. She still have a pressure difference between upper and lower extremity, but no upper extremity pain or vertebral stenosis, vertebral steal syndrome, so we just left her here. Obviously, this is ongoing management, but just see how challenging it is managing the supraortic trunk and carotid disease.
This is a very interesting and challenging case, and I commend you for at least the outcome. Let me ask the audience, would anyone leave this woman alone, never touch her? And for all practical purposes, back to what we talk about, asymptomatic patient, when we say there's non-hemispheric symptoms. And if anybody reads similar to what I did, stroke cancer with American Heart over 15, 20 years ago, put really definition, how would you define vertebrovascular insufficiency? Dizziness alone, vertigo alone, blackout alone, you must have a minimum of 2 of 14 symptoms combined and rule out every other etiology for that symptom before you think these people are probably global ischemia. It's feasible, she does, but she looks so out of it. I'm really shocked she's living 3 years later and she still drives from Phoenix to Tucson, unless she drives a camel or something, you know what I mean?